We will straight away start the program. Uh, the today's program will be we will be having two speakers. Uh, First speaker is Dr. Lakshminarayanan K. and second speaker is Dr. Vikram Muthu Subramanian. So at the end of both the talks, we will be having the questions of quiz from the talk. And those who are answering promptly, fastly, will be awarded. They have to put it in the chat box. That is the main thing. So actually, this month, every month we are conducting this program. This month, the day which is coming here is the National Epilepsy Day, which was on 17th. So that's why it is coinciding with our program. Yesterday only it was there, and nowadays a lot of people are not at all conducting any awareness programs, or the CM is also. That's what's happening. We have a lot of forums, which we have a MSI, this neurophysicians forum, and all those things. No one is interested in conducting any of the meetings for the days, or even they are not conducting the programs. So, but we wanted to conduct every month what are all the things are there. Last month we had the stroke. Before that month we had the dementia like that. Next month it is going to be AIDS. So AIDS will be covered in that. So like that, we will be having the interesting topics. And so immediately we thought of having new speakers. So we got Dr. Lakshminarayanan K. Naveen, Dr. Lakshminarayanan is going to give a talk on the topic simple approach to seizures, because seizures are very, very difficult to treat in some of the cases. Dr. Lakshminarayanan is a consultant epileptologist and pediatric neurologist in the Advanced Center for Epilepsy, the Evangels Healthy City, Chennai. He did MD Pediatrics and DM Pediatric in Neurology from the All India Institute of Medical Sciences, New Delhi. He is having a fellowship in epilepsy 2 years at the Royal Children's Hospital, Melbourne. He is a faculty of Asian Epilepsy Academic of EEG and Epilepsy course for neurologists. He is a member ILAE Pediatric Epilepsy Surgery Task Force. Carrier interest, drug-resistant epilepsy and epilepsy surgery and stereo EEG. Many publications in reputed journals, including Brain, Annals of Neurology, and Epilepsy. So I welcome Dr. Lakshminarayanan to give his lecture.
Thank you, sir. Very good evening, all of you. So first of all, I would like to thank Dr. Rajesh Babu sir and Dr. Vikram for inviting me for this talk. So as it was mentioned already yesterday, November 17th every year is celebrated as National Epilepsy Day for creating awareness. So we thought today's talk, it is apt to have epilepsy topic. So I'll be talking about how to approach seizures simply. So simple approach to seizures. So in the next 30-40 minutes, we'll be discussing more about seizure. I hope this will be useful to you, because seizure and epilepsy is one of the most common neurological disorder for any age. So the today's talk, what I'm going to cover, will be applicable to all the age groups from infancy to adults. So it is not specific to pediatric epilepsy alone, but this can be applied, the broad principles can be applied from infancy to adult and elderly. So that is how I designed my talk. So what is a seizure? How to diagnose? One of the most misunderstood tests is a EEG, how to demystify some of the myths, how to treat epilepsy, and what are the most commonly asked questions and summary. So this is how we'll proceed. So before going into the topic, most of you would have treated any patient with a seizure. Okay, let us say this scenario, which is not very uncommon. A 5-year-old boy comes to the emergency department with the first episode of what is described as a seizure. Okay, so how it proceeds? Say, for example, this is in the middle of the night. So admission is advised, and child is loaded with levetiracetam, MRI brain is ordered, mostly it will be done next morning. One EEG will be recorded and child will be started on levetiracetam and child will be discharged home. Okay, so most of you would have come across this, but so life is not such simple thing, you know. So if treating seizure is such simple, only 6 points: admission, loading, MRI, EEG, maintenance, and discharge. If it is so simple, you wouldn't be here today listening to this talk or wasting your next 1 hour of time. Okay, we know that this is much more complex than this. So where are the points where we can tailor this? Okay, so first and foremost, whether the patient presented to you, is it a seizure or seizure mimic? That is the single most important. This may not be seizure, what the mother or parents thought was as a seizure, but maybe seizure mimic, maybe syncope. The patient presented to you with the syncope, for which MRI brain is not useful, loading with levetiracetam is not necessary, giving him levetiracetam for next 2 to 3 years is unwarranted. So we need to be careful what we are dealing with, whether it's a seizure or not. So that is an important point I will be dealing with. The next, where all we can tailor this approach, precision medicine. So possibly, even if it is a seizure, this may be a very common scenario in a 5-year-old boy, can present with the first episode of what we call Rolandic seizure, benign Rolandic epilepsy. If it is a benign Rolandic epilepsy, for a first episode, we wouldn't give loading dose and we would not admit the patient. We would not get a MRI because benign Rolandic epilepsy is a electroclinical diagnosis. You get a history, what is a seizure, and the EEG can confirm benign Rolandic epilepsy pattern, and you can just prognosticate that this is a nocturnal brief seizure, doesn't do any harm. We can wait and watch, no need for medication. So likewise. Or if the EEG confirms benign Rolandic epilepsy, I would not order for MRI because we know benign Rolandic epilepsy, there is no role for MRI because MRI will be mostly normal. Even if it shows some remote etiology, we are not going to alter any treatment based on the MRI. And if it is a brief episode, no need for maintenance anti-epileptic medication for this patient. So at multiple level, we can precisely tailor this treatment for that individual patient. So we need to know more about the seizures rather than having a one-size-fits-all approach. So in this common scenario, what are the questions that we come across? So the first and foremost question is it a seizure or seizure mimic, syncope or psychogenic episode? If it is a seizure, whether it's a provoked seizure or unprovoked seizure, if it is a provoked seizure, we have to look at the underlying cause and remove the underlying cause. That is a treatment approach for provoked seizure. Is there underlying cause which can be treated? We have to definitely look at that. And what are the investigations to be done? When will it recur? The single most important question a parent would ask when they come to you with seizure, sir, when will it occur? Will it occur again? So that we need to answer, and what kind of treatment and how long we need to give. So these are the common questions that we come across. Any patient for that matter, any age for that matter, who presents to you with the seizure. So what is a seizure? Basically, it's a transient neurological symptom. Seizure is a transient neurological symptom, which is a result of uncontrolled and synchronous electrical discharge. Any neurological symptom which can be attributed to abnormal electrical short circuit in the brain. So that is what is a seizure. How it can present? It can present as altered awareness, unresponsiveness, abnormal jerky movements, sensory disturbance, autonomic changes, or behavioral changes. All these are different symptoms by which seizures can present. So any transient neurological symptom, why it is transient? It can last for only few minutes, few seconds, if at all maximum up to 10, 15, 20 minutes. Beyond that, we would call it status epilepticus. Okay, so seizures, about 99% of the times it is less than 10 to 15 minutes. So any paroxysmal movements, even in children or adults, these are very common. Paroxysmal movements, what we call sudden onset, sudden offset, any altered behavior. So that is a paroxysmal movements. Any jerky movements, shock-like movement, all these are very common. So distinguishing this between a seizure or non-seizure or non-seizure mimic or non-epileptic paroxysmal event is purely a clinical diagnosis. Why I'm emphasizing here again? Because this cannot be outsourced. There is no one single investigation which will tell you, okay, the episode that this child had just now had is a seizure or not a seizure. There is no investigation like that at all. So this is purely a clinical judgment, purely a clinical diagnosis, will be based on many factors. I will enumerate how we come to this clinical diagnosis. This is the single most important critical first step. If we go wrong in this first step, all the subsequent steps will be wrong. So that's why we need to be careful before labeling any child with a seizure disorder, or epilepsy. So how do we diagnose this clinically? Single most important point is to have a careful, in-depth, detailed history, mostly from eyewitness, because patient themselves, patient him or herself will not be able to give you the history because they might have had amnesia for the event. They might not be aware of the event, no recall, unconscious, unresponsive at that time. So you need to get the history from the first-hand eyewitness. That's the most important thing. So what are the things that we ask in the history? What is the context? What was the patient doing just before the episode? The context, whether the patient was running or walking or sitting in the classroom or standing in the school assembly or bathing or sleeping. What was he doing? Then how did it start? What was the very first symptom? How did the progression occur of the episode? What are the second symptom, third symptom? What is the sequence? And how did it end? And what happened just afterwards? So all these things are very, 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 very important history. And many times, if it is a younger child, many patients just get the history, many doctors get the history from only parents. It is not a good idea, because the child will be the only person who will be able to give you the history of aura, what he felt just before the seizure. Aura. That will give you the whole lot of information about the episode. Say, for example, in vasovagal syncope or other forms of syncope, prodrome, which is again a subjective sensation, only the patient can tell you. So we need to talk to the patient if the child is able to describe what are the symptoms they had. Get the eyewitness to act out. Maybe many times they may not be able to describe you in words, but they can show you how the jerking was, how the child behaved. Many times the events occur at school, so we talk to the teacher over phone to get what was the first-hand witness history. Nowadays, most people have a smartphone, so home video, if they are available, is the single most important piece of information for you to clinch the diagnosis. So again, to re-emphasize, situation and context is the most critical, and overall flavor is very important. Many times people get stuck with, okay, was there eye blinking? Was there uprolled eye? Was there a tongue bite? Was there a urinary incontinence? Okay, if one feature is there, I will decide this is seizure. No. Tongue bite can occur in psychogenic non-epileptic event. Tongue bite can occur in syncope. Tongue bite can occur in seizure. Okay. Urinary incontinence rarely can occur in psychogenic events. So no one single feature will give you the diagnosis. You have to have a whole overall flavor. So encourage home videos. That's very important. The most important differential diagnosis for any seizure is a seizure mimic. Of course, this depends on the age. Seizure mimic in pediatric age group is different. In adult age group is different. Okay. So in pediatric age group, will be, if it is an infant, breath holding spell, shuddering attack, stereotypies, daydreaming, tics and parasomnias. But most common in any age group is syncope. In an elderly, it can be cardiac syncope. In a younger patient, it can be vasovagal syncope. So this is the most important differential diagnosis for a seizure. Psychogenic non-epileptic events, which is much, much more common than what we think. In any age group, it can occur, but more frequently in adolescents and young adults, more frequently in women, psychogenic non-epileptic events. So they are more common, and most patients are many times misclassified as epilepsy, and they are on treatment for years together with 4 or 5 anti-epileptic drugs before actually the correct diagnosis of psychogenic non-epileptic attacks are made. And many patients with epilepsy can present with psychogenic episode also. So the same patient can have a seizure as well as pseudo seizure. So that is an important combination. We need to differentiate which episodes are epileptic seizure, which episodes are psychogenic pseudo seizure within the same patient. It may be sometimes difficult, but videos will clinch the diagnosis. Rarely we do get a video EEG to completely come to a conclusion. So coming to the next point, if it is a clinical epileptic seizure, whether it is a provoked seizure or unprovoked seizure, this is a very important concept to understand. So provoked seizure is otherwise known as acute symptomatic seizure. Basically, the seizure that occurs in a close temporal association with an identifiable reversible trigger. Basically, they have an underlying cause. Basically, they have an underlying precipitating factor. So that is acute symptomatic seizure. The most common example being hypoglycemia, hyponatremia, hypocalcemia, alcohol withdrawal, drug intoxication, any medication related, meningitis, encephalitis. These are the common scenario for provoked seizures. In children, the most common provoked seizure is a febrile seizure, fever, provoking. Hypoxia or stroke or trauma within the first 7 days, all these can present as provoked seizures. The important point here is, if it is a provoked seizure, then the most important investigation should be to identify the underlying cause. Okay. And because the treatment of provoked seizure is only the treating the underlying cause. And this is all not epilepsy. And after correction of the underlying cause, after the trigger has been removed, they may not have any recurrence of seizure. That is the single most important thing. Seizure recurrence in future for provoked seizure is rare. And you don't have to treat with a continuous long-term anti-epileptic medication. And provoked seizures are not epilepsy. Right. Whereas unprovoked seizures, usually there won't be any identifiable cause, and the recurrence risk is very high. 40 to 60% will have another seizure if it is unprovoked seizure within the next 2 years. And we do consider long-term anti-seizure medication, and this is possibly an indicator of future epilepsy. If it is a first unprovoked seizure, it may be a harbinger of future epilepsy. So coming to what are the etiology, the single most important point to understand is epilepsy is not a single disease. It's like, unlike your myocardial infarction or diabetes. So it's not a single disease. It's basically an umbrella term. The common denominator being unprovoked seizure. Recurrent, multiple, unprovoked seizures. That is the definition of epilepsy. Okay. So it's a heterogeneous disease. Multiple etiologies can be causing seizures and epilepsy. And the etiological factor, etiology is the single most important determinant of the overall outcome and prognosis of the patient. Say, for example, a patient has idiopathic epilepsy. There is no cause. After extensive evaluation, there is no cause. Say, for example, childhood absence epilepsy. Childhood absence epilepsy. Absence seizure, absence epilepsy, all of you would have heard of. So that has an excellent prognosis. You treat with sodium valproate or ethosuximide. After 6 months, 1 year, you can stop the medication and the child will never have any seizure in the future. So that is an excellent prognosis. On the other hand, a child who has a severe hypoxic ischemic encephalopathy in the newborn period at birth, perinatal asphyxia, having bilateral cerebral gliosis causing severe epilepsy, that child recurrence risk for future is high and complete remission is less likely in that child. So the etiology is the most important determinant of the long-term outcome. So there is a mnemonic. Many of the youngsters might remember this mnemonic. It's called vitamins. Vascular cause, which is a stroke or other causes, can cause epilepsy. Infections, many post-infectious, post-meningitis sequelae can cause, especially TB, tuberculoma, TB meningitis, neurocystic sarcosis, all these can cause epilepsy. Trauma, head trauma, gliosis, post-traumatic epilepsy can occur. Autoimmune encephalitis, autoimmune can occur. Metabolic can occur. Idiopathic, you may not be able to identify the cause, and psychiatric comorbidities can also cause epilepsy. So this is one mnemonic, vitamins. So coming to precise diagnosis, how we diagnose epilepsy, first we have to analyze what is the seizure type, whether it's a focal seizure, whether it's a generalized seizure, whether there is eye blinking, whether there's eye deviation, whether there is a jerking of one limb or both limbs or both sides or one side. So we go into the semiology and seizure type. There are many different seizure types. I'm not going to go into the exhaustive details of all the seizure type. So depending on the seizure type, we can decide whether it's a focal epilepsy or generalized epilepsy. So epilepsy types are two, focal or generalized. And there are epilepsy syndromes. Say, for example, benign Rolandic epilepsy, West syndrome, juvenile myoclonic epilepsy, mesial temporal lobe epilepsy. All these are epilepsy syndromes. So these are the three axes, three different categories: seizure type, epilepsy syndrome. So this is one cartoon you would have seen already. This is given by International League Against Epilepsy, ILAE. So basically, again, it says the same thing: seizure types, which can be many different: focal aware seizure, focal unaware seizure, tonic-clonic seizure, absent seizure, myoclonic seizure. All these are seizure types. Epilepsy types: focal epilepsy, generalized epilepsy, and a newer term they have introduced: generalized and focal combined epilepsy or unknown epilepsy. So epilepsy syndromes, I gave you some examples. And all these can be due to multiple different etiology: genetic etiology, structural, metabolic, immune, infection, and unknown. All these are the most common etiology. And there are comorbidities like anxiety, depression, hyperactivity, ADHD. All these are comorbidities for epilepsy. So all these different points we need to consider when we diagnose a patient with epilepsy. So coming to the investigations, the EEG, as I already mentioned, EEG is one of the most misunderstood tests. Why I'm saying that? Because physicians, either they overtrust it, which it doesn't deserve, or they mistrust it, or they misread the interpretation. Rarely it is interpreted in the context. So that's why we have these myths and misunderstandings about how EEG works. In next 5-10 minutes, I'll give you some salient points how to better use EEG. One of the most common myths that physicians and pediatricians have is a normal EEG rules out epilepsy. This is a myth, okay? Because normal EEG does not rule out epilepsy. Why this is important? Say, for example, a patient presents to you with seizure. Actually, it's a seizure. But the EEG comes back as normal. So many times people think, okay, EEG is normal, so this is not a seizure. Okay, this may be syncope or seizure mimic. So the real opportunity for the diagnosis of epilepsy, the first seizure episode is missed. So that's why if you clinically diagnose a patient with seizure, the EEG comes back as normal, it's okay. Because only 30, 40, 50% of patients get abnormal EEG after first episode of seizure or after the first time that you get EEG. Okay, so there are ways to get a high quality EEG with high yield. So you do sleep deprivation, photic stimulation, hyperventilation, sleep recording. All these if you do and record for 1.5 hours, then the diagnostic yield goes up to 80 to 90%. If you just get a routine EEG for 20 minutes awake, so that yield, that diagnostic yield is only 30%. So normal EEG does not rule out epilepsy. It's the most important thing to understand. So how do we think about EEG and what do we expect from EEG? The simplistic thinking most physicians have, okay, this is Cori seizure, paroxysmal episode, and I do EEG. If it is abnormal, it's epilepsy. If it is normal, it's not epilepsy. So this is a simple thinking most physicians have. And where do we get this simple thinking from? Because this is the ECG analogy. Any patient who presents with emergency room with the ECG, any ECG change is there, it is cardiac chest pain. The ECG is normal, it is non-cardiac chest pain. That's how we are taught. Okay, this is true for 95% of the patients. Rare exceptions are there. Even ECG can miss acute MI. That's an exception. But rule, any ECG abnormality, it is cardiac. Any ECG normal, non-cardiac chest pain. So this is how we were taught. But the same ECG analogy will not hold true for EEG. So that is why I again emphasized normal EEG does not rule out epilepsy. So we already saw that. Second point, abnormal EEG. Does it automatically confirms epilepsy? That is also not true. So the fact is EEG only supports the clinical diagnosis of epilepsy and EEG is not a confirmatory test. So any EEG report comes back as abnormal, this is automatically not a diagnostic of epilepsy. I will give you a simple scenario. Say for example, a patient, a child, 10-year-old child, he is in 5th standard, he is standing in school assembly meeting in the morning, very hot, humid day. He didn't sleep well previous night, had some vomiting, had a URI, upper respiratory infection, and he did not eat well on the morning. Okay. Suddenly he collapsed, unresponsive. in the school assembly meeting. So this we have come across every time. All the doctors would have come across this scenario. Any child who comes to you from school in the school uniform has a sudden collapsing in the school assembly meeting, right? So this is vasovagal syncope. I gave you all the uh, uh, settings why he had that episode that day. But you order a EEG, say for example, the ideal situation would be you go into the history and you ask the child what was the premonitory symptoms, prodromal symptoms. Yeah, he will be saying, yeah, I had an nausea, I had a little bit of tummy ache just before I fell down, and there was a blurring of vision, there was a graying of vision before I fell down. Okay, if that confirms, this is clinically vasovagal syncope. Ideally, I would not order EEG for this patient because it is a seizure mimic. It is not a seizure. But most people would order EEG. And EEG will come back as abnormal most of the times. Okay. So if you clinically know this is a vasovagal syncope, even if EEG comes back as abnormal, you don't take it as epilepsy. That's the most important point. If you want to take 1 point from today's talk, so this is the most important point. If it is a seizure mimic, you are sure by the clinical history and evaluation because it's a clinical diagnosis. Then please don't order EEG. That's the first step. If you order EEG, if it comes back as abnormal, that does not automatically means that this is epileptic seizure or epilepsy. So this is a single most important message from today. So in a nutshell, till now what we have understood, a normal EEG does not rule out epilepsy. An abnormal EEG per se is not diagnostic of epilepsy. So this is what we learned till now. So the most important point, why I am emphasizing that is, we need to treat the patient and not the EEG report. That's why. The third myth, EEG differentiate between seizures and seizure mimics. So this is again many people. Okay, I don't know whether it's a syncope or seizure. Let me get a EEG, then it will clarify. Again, I already mentioned this. Seizure and epilepsy are clinical diagnosis, and EEG is not going to give you this differentiation at all. Okay, so this is the third myth. So what are the indications for EEG? So you know that this is epileptic seizure. Okay, I know this is absent seizure. I know this is a focal seizure. So let me get the EEG. If it is a absent seizure, I'm getting 3 Hz spike wave, then that confirms it is an absent seizure. Okay, so it supports my clinical diagnosis of epilepsy. So that is the single most important point. Second, classification of epilepsy into focal generalized epilepsy. If there are focal spikes, okay, this is focal epilepsy. If there are 3 Hz generalized spike, it's a generalized epilepsy. And specific electroclinical syndrome, infantile spasm, West syndrome, benign Rolandic epilepsy syndrome, mesial temporal lobe epilepsy syndrome, like that. So for that, you need definite EEG because all these syndromes are EEG-based electroclinical diagnosis. Prognostication recurrence risk can be predicted from EEG, and the AED medication before withdrawn, EEG is done. Evaluation of first ephemeral seizure, EEG is done. Exclusion of non-convulsive status epilepticus after a prolonged status epilepticus and patient is in comatose condition, that is example for indication for EEG. So the next myth, the most important one is follow-up EEGs are useful to monitor treatment. So many patients will be coming to you over the last 5 years. Patient had at least 5 or 6 EEGs, every year one EEG, just to see whether the treatment is working. So that is not useful at all. So EEG is only for diagnosing the epilepsy. Every year, every 6 months getting EEG is not useful at all. There are exceptions to this rule, but as a rule, we do not get EEG for monitoring periodically the treatment response. So when not to do EEG, that's also important. Most of the time, the most common indication for EEG, at least in pediatric age group, it's a fever-related seizure, febrile seizure, typical, atypical. So in this scenario, whatever the EEG abnormality may be, I'm not going to start the patient on anti-seizure medication. So long-term prognosis is not altered by abnormal EEG. So I don't do EEG for febrile seizure. Autism, any patient with autism, but never had seizures. Even then people order EEG. Okay, I'll see EEG. No, for autism alone, without epilepsy, no EEG. If the autism patient has epilepsy, then EEG is fine. So to differentiate between psychogenic non-epileptic event and seizure, again, EEG should not be done. For all the seizure mimics, headaches, dizziness, syncope, all these seizure mimics, please do not get EEG. For a periodic monitoring, do not get EEG. I think till now that is clear. The another important myth that people have about EEG is EEG spikes are ongoing seizures. These cause brain damage. Okay, so they go on increasing the medication. Say, for example, a patient comes to you who is diagnosed as focal epilepsy on medication but never had a seizure recently. You again do a EEG for periodic monitoring and the spikes are there. Okay, I'll show you what are the spikes. So then thinking that, okay, that spikes are not gone, so the seizures are still there, another medication is added, the dose is put up. So that is not to be done because the EEG spikes are interictal finding. It is not the seizure. It's not a ictal. It's a interictal, in between seizures. And these are per se not seizures. And the spikes alone do not cause any brain damage. So that is the. So this is a EEG example. The red circles there showing spikes, what we call focal spikes. Okay. So these spikes are basically in between seizures, interictal findings, not seizures. Okay. So these are basically signature of the epileptic brain. If you like, it's a biomarker. Okay. Most commonly noted in people with epilepsy and the marker of an epileptic brain. And these are not seizures. These are not to be treated on their own. So if the clinically seizures are not coming, no problem. Just continue the same dose. Don't increase the dose for EEG findings. Coming to treatment, some basic aspects. As I already told, the epilepsy is not one single disease. So we need to have a different approach depending on the individual situation. So the treatment is one size fits all will not work in epilepsy. We need to have a tailor-made treatment depending on the precise diagnosis, depending on the individual characteristics of each patient. So we need to individualize. We start with a single anti-seizure medication, low dose, and gradually tighter upwards. We ensure compliance. If there are recurrence of seizure, first and foremost important question is whether are you taking the medication regularly. That's the most important thing. So as much as needed is very important, but it's only as little as possible. Okay. Many times this sounds very simple and a simple logical English, but this is the most forgotten aspect of anti-seizure medication. They'll go on increasing the medication dose. So as much as needed, fine, but it's only as little as possible of the dose. So various patient-specific, drug-specific, and other specific variables are there. We consider all these: age, gender, co-medication, comorbidities, what are the dose, adverse effects, all that we go through, then we select a medication. So what medication to choose for which epilepsy depends on the epilepsy syndrome, precise diagnosis. That's why earlier emphasized to get a precise diagnosis. If it's an infantile spasm, of course, you need a ACTH or oral prednisolone or vigabatrin. All other medication like phenytoin, phenobarbital is not going to work. Focal epilepsy, the most common medications are carbamazepine, oscarbazepine, phenytoin. Absence epilepsy, the drug of choice is ethosuximide or valproate. Benign Rolandic epilepsy, many times we don't give treatment. If it is needed, valproate is good enough, clobazam is good. In JME, juvenile myoclonic epilepsy or idiopathic generalized epilepsy, if it is boys, the treatment of choice is valproate. Because of the teratogenicity and various side effects, PCOD syndrome, all that, in girls, valproate is avoided. So levetiracetam, lamotrigine, brivaracetam, zonisamide, all these can be used for idiopathic generalized epilepsy or juvenile myoclonic epilepsy in women and girls. Just one small case scenario: 3-year-old girl who was recently diagnosed with autism, presented with 3 affable seizures in the last 1 week. A pediatrician started the patient on levetiracetam. What is the problem? She became very violent, hitting everyone in the family, crying, running amok, self-harm, all that. So the mother complained, this child became completely a different child in the last few days. So the problem was levetiracetam is not a good medication for child with autism, hyperactivity, any patient with depression, anxiety, irritability, mood swings. The levetiracetam is not a good medication at all. So this is one of the characteristics we need to assess. Before starting a patient on levetiracetam, we need to choose whether there is autism, ADHD, hyperactivity, depression, and mood swings. In these patients, better you avoid levetiracetam, give another medication, because this is notorious to cause such a devastating behavioral issues. And this is a very common problem. Okay? We have to choose the right medication for the right patient depending on various different factors. So you have diagnosed a child with epilepsy and started on first medication, and the patient continues to have seizures. Okay, so this is a common scenario, right? So you started the patient on first medication, but doesn't work, continue to have seizures. So in that scenario, we revise the diagnosis. Is it epilepsy? Is it a seizure only, or it's something else that I'm treating as seizure because it is not effective, the medication is not working? And then the second question would be, if it is a seizure and epilepsy, correct diagnosis, then whether the chosen medication, is it correct? For each epilepsy syndrome, there is a drug of choice. So whether it is the drug of choice which I have chosen, or it is an ineffective drug for that epilepsy syndrome that I have chosen. If it is the right drug and the right patient, then the third question is it the dose which I am giving is the right dose? Or is there a scope to go up on the dose? So most important question. So the first AED fails if it is partially effective. Say, for example, patient had 10 seizures in 2 months and you started the medication and had only 2 seizures the last 2 months. That is partially effective. So you can add another medication as a combination, or you change over to another monotherapy. So it's called add-on or substitute monotherapy. So that is the situation. On the other hand, instead of 10 seizures in 2 months, this time the patient had 12 seizures in the last 2 months. That means it's not effective at all. Or seizures are not there at all, but the child is completely a zombie or completely a behaviorally abnormal child. That is undesirable side effect. So you need to, of course, change the medication to another medication, alternate monotherapy. So these are the scenarios we look at. What are the common causes for AED failure? Non-compliance. That is one of the most important cause for recurrence of seizure and AED failure. Other causes can be vomiting, loose motion, intercurrent illness, fever, especially in children. Any child with epilepsy, fever can trigger seizure. It is not febrile seizure. Any child with a diagnosed epilepsy, fever can trigger a seizure during illness. Inappropriate AED choice, inadequate dose, all these are the common causes. So this is a long-term population-based study. In that, basically what they found, any patient who comes to you with, say for example, you are treating 100 patients with the first medication, only 50% of patients will respond to the first anti-epileptic medication. Okay, irrespective of what medication you choose, around 50% will be seizure-free. The remaining 50%, you need to add second medication, third medication, a combination of medication. Then another 15% will be seizure-free after the third medication. So around 2/3, 65% of patients will be seizure-free after first, second, third medication. Despite all these, there will be a 1/3 of patients, nearly 30-35% of patients who are not seizure-free. This is called drug-resistant epilepsy. So basically, failure of appropriately chosen, adequately given dose, 2 anti-seizure medication. Failure of 2 anti-seizure medication is called drug-resistant epilepsy. So what do we do in drug-resistant epilepsy? We try to give some other medication, combination of different medication, add-on medication. If that fails, then ketogenic diet is there. Ketogenic diet is one of the very effective treatment for drug-resistant epilepsy. Vagus nerve stimulation, deep brain stimulation, all these can be tried in drug-resistant epilepsy. Epilepsy surgery, which is an important treatment aspect for drug-resistant epilepsy. I'll give you a few words about what is epilepsy surgery. Basically, it's a neurosurgical procedure that removes, disconnects, or disables the part of the brain where seizure arises. Say, for example, this is a part where the seizure arises. We can remove that small part or disconnect that part from other brain region so that the seizure doesn't spread and doesn't come out. So there are various different procedures are there. So we do detailed pre-surgical evaluation to localize precisely the accurate localization of the brain region where the seizure onset zone is, what is called seizure onset zone. Whether it's possible in all the patients with drug-resistant epilepsy, no. It's only for select people where there is a very focal or very unilateral seizure focus which can be safely removed or safely disconnected, then you can offer epilepsy surgery. So this is one major chunk of proportion of patients in drug-resistant epilepsy. So we do various different testing to lateralize, localize, determine the functions, determine the surgical procedure and safety. So this is the single most important, safe and effective treatment of choice when there is a well-defined epileptic focus that can be removed without sacrificing eloquent function. The another important aspect to understand is many people think, okay, all the medications are exhausted, all the medicines are failed, then only epilepsy surgery is done? No. Say, for example, a patient who has a very small tumor, glioma, that causes epilepsy, which is called a long epilepsy-associated tumor. Obvious that you have to remove the tumor to make the patient seizure. You don't have to fail 10 medication before we remove the tumor. Similarly, there are some cortical malformation, focal cortical dysplasia, focal gliosis. All that can be a cause of seizure and that can be easily removed. So if there is a focus, first 2 or 3 medications failed, drug-resistant epilepsy is there, then you have to do epilepsy surgery. Earlier, the better. So careful case selection is the most important part. And there is something called surgically amenable epilepsy. Okay, how do we identify these patients with surgically amenable epilepsy? So we need to look at seizure semiology and MRI finding. For non-neurologists, it's mainly MRI finding. So neuroimaging is the key. So any patient who has a unilateral disease on the MRI, unilateral lesion on the MRI, can be malformation, can be gliosis, can be hemiatrophy, or any unifocal atrophy, gliosis, scarring of the brain, or there is a mesial temporal sclerosis or hippocampal sclerosis, or there is a glioma tumor, or there is a focal cortical dysplasia, or there is a tuberous sclerosis or sturge-weber syndrome, tram track appearance, calcified posterior cortex. All these kind of neuroimaging MRI showing focal lesions are amenable for epilepsy surgery. Any such patient you come across, you should immediately refer this patient to higher center for evaluation. Another important point, till now I have shown you all the abnormal MRI. So I told you, if any of these MRI are there and the patient has a repeated seizure, despite medication, this patient needs to be evaluated for epilepsy surgery. That does not mean MRI normal that we cannot do surgery, because many times there may be subtle lesion which can be easily missed. So the dictum is any drug-resistant epilepsy patient, DRE is drug-resistant epilepsy patient, any patient irrespective of the neuroimaging finding, you have to refer them for comprehensive epilepsy evaluation, because initial multiple serial MRIs can be normal before we pick up, there is a small focal cortical dysplasia there, after a detailed evaluation in an experienced epilepsy surgery center. So just last case, I'll show you one brief video. So carefully watch this child. You may be wondering why this child is walking with the helmet on. Watch carefully. Okay. So the child was trying to open the door and suddenly fell down. This is called drop attack, atonic seizure, drop attack. I can show you the frontal view of that. So he falls suddenly like that. Okay. So that is the reason why he was walking around with the helmet, because he can fall down anytime. Sudden fall can cause injuries to the head and face for him. That's why he was doing that. So this child, multiple medication, never became seizure free. MRI was actually normal. We could not localize focus right or left. So this patient underwent what is called corpus callosotomy. So disconnection of the corpus callosum. And this is many years ago, this patient, nearly 2018, I think, 2018 or 19. So after the procedure, completely seizure free now. So this is what epilepsy surgery can do for you. Okay. Any number of medication will not cause seizure free, but epilepsy surgery can cause seizure free for such patient. So epilepsy surgery is a curative option. There is hope for everyone. So when to refer the patient? Infants who fail on first seizure medication, children who fail on 2 anti-seizure medication, or any patient for that matter, any age, who fail on 2 anti-seizure medication, because that is a drug-resistant epilepsy. Any focal lesion on MRI, I showed you multiple examples of focal lesion. Any difficult to treat epilepsy, infantile spasm, tuberous sclerosis, these are notorious for difficult epilepsy. Metabolic disorder, surgically remediable epilepsy, any unwarranted or uncontrollable medication side effects. All these are a patient that needs to be referred to a center which is a comprehensive epilepsy center. To summarize, take-home messages, the epilepsy treatment is tailor-made. Choosing the right medication is an art. We need to always keep in mind, we need to treat the patient and not the EEG reports or MRI reports. Treatment of epilepsy can be very cost-effective. Epilepsy surgery is a curative treatment option, and Whenever patient not responding to the first or second anti-epileptic medication, we need to refer these patients to higher center for comprehensive epilepsy evaluation. So with that, I conclude. Thank you for the invitation once again, and thank you for your patient listening.
Thank you, Dr. Lakshminarayan sir. We will be having questions at the end of the second talk. So now we will move on to the second topic of the day, intraoperative neuromonitoring in neurosurgery by Dr. Vikram Muthu Subramanian. Dr. Muthu Naveen. Dr. Muthu Vikram Subramaniam is the senior consultant neurosurgeon in HOD Department of Neurosurgery, Sri Ramakrishna Multi-Speciality Hospital, Coimbatore. He did his MBBS from Tumkur, Karnataka, and he's done a DNV from the Voluntary Health Services, Taravani, Chennai, and fellowship. Dr. M. Vikram underwent a fellowship in functional neurosurgery involving deep brain stimulation, epilepsy surgery, spasticity, and pain therapy under the guidance of Dr. Paresh Doshi at Jaslok Hospital, Mumbai. Minimally invasive spine surgical techniques like foramenoscopy, percutaneous pedicle screw fixation, etc., under the guidance of Dr. Sarat Chandra Gore, Pune. Expertise, 19 years of experience in clinical practice involves more than 3,500 cases of neurosurgical procedures like minimally invasive spine surgeries like cervical and lumbar endoscope, neuroendoscopic approaches involving intraventricular tumor removal, CSF diversion procedure like endoscopic third ventriculostomy, and skull-based and extended transnasal endoscopic surgery, functional neurosurgical procedures, baclofen pump for spasticity, temporal, extratemporal epilepsy surgery. Now I invite Dr. Vikram Subramanian for his talk.
Thanks for a nice introduction. Let me share the screen. Hope my screen is visible and I am audible.
Yes, sir, audible.
Thank you. Thank you a lot, sir. Good evening, everybody. Thanks for participating in our CME of Neurosciences Forum. Intraoperative neuromonitoring in neurosurgery. This is my talk, and previously for generations, we have been operating neurosurgery without intraoperative neuromonitoring, where we don't know how the brain is functioning, whether the cranial nerves what we are operating are safe, and the cortical mapping was not there. So we were unaware what happening to the neurological structures during our intraoperative go through into the neurosurgical corridors. Thanks to the advancement in neurooperative neuromonitoring, where we can intraoperatively lively monitor the functions of the cranial nerves, the cortical tracts, and the peripheral nerves, so that our surgery becomes safer. What all the types of intraoperative neuromonitoring systems we have? It is like from electromyography, electroencephalography, motor evoked potential, facial motor evoked potential, or all cranial nerve motor evoked potentials, triggered EMG, which can be bipolar or monopolar, somatosensory evoked potentials, D-wave monitoring, brainstem auditory evoked potential, visual evoked potential, and corticography, which is mainly using during the awake craniotomy and mapping the cortex during the glioma surgeries. To go by one, the electromyography plays a crucial role in intraoperative neurophysiological monitoring because it records the electrical activity of the muscles, indicating the integrity and the function of the muscle. EMG helps surgeons to detect and prevent nerve injury in real time, especially in procedures like cranial nerves and peripheral nerves, because basically we all know the action potential, and as soon as we get the nerve stimulation, depolarization, repolarization, this process of recording that continuous electromyography helps us to understand if there is any disturbance in the electromyography that indicates the nerve is getting irritated. So we can identify what is happening to that group of nerves. Mainly this EMG monitors spontaneous or triggered muscle activity, which can indicate when the nerve is getting compressed, injured during the surgery. Sudden burst of EMG will help us to identify. This will help us to identify whether we are close to the nerves, and we can prevent and avoid damage to these nerves. The other part is the triggered EMG, where when we are close to the nerve, when we are irritating the nerve, like in many peripheral nerve tumors, as soon as we dissect the motor root, there will be surplus of EMG burst which will go, which will help us to understand that this is a part of the motor root. The same thing which we can use for cranial nerves also. When we are handling that along the course of the tumor, it will help us to identify that we are close to the nerve. These all monitoring is done by the neurophysiologists who help us to tell, sir, there is a lot of EMG changes which is happening in 7th, in 8th, or the motor nerve, whichever we are close to. That will tell us that we are close to the nerve, and we can plan our surgery without disturbing the nerve or protecting the nerve. Mapping nerves is very easy and very useful for us to define where the pathology is, and we can plan our instrumentation. The same thing holds good when we are doing the spine instrumentation as well. Triggered EMG in spine surgery is very useful, that too when we are using spinal cord tumors. It is usually done with 1 to 10 milliamps and 20 to 500 milliseconds, so that once we apply the triggered EMG, we know what roots we are handling with. Suppose if there are multiple roots at the cardia equina and there is a tumor, when we are handling, if we are not sure what roots which is getting attached to the tumor, by giving this triggered EMG, bipolar or monopolar stimulation, we will know what group of muscles are getting stimulated when the leads are placed in the muscles. So we can plan accordingly. If it is a sensory root, many times we may not see any motor response, or we don't see triggered EMG. Those small roots can be compromised, and the vital motor roots can be safely dissected and preserved, even if we have to leave a small portion of tumor along the course of the root. Multimodal monitoring is the standard for the day, where along with EMG, we use motor evoked potential, somatory sensory evoked potential to decide what exactly is happening. Are we compromising the cortical tracts? Are we compromising the roots? Or are we compromising the motor or sensory tracts, which we can help and make our changes in our surgical modality according to it. So this is next, the main topic is our electroencephalography. Sir has clearly explained in his previous talk what are all the EEG findings which you can get, the normal waves, abnormal waves, spikes, and which we have to give importance, where we can avoid. The same thing is very much useful even for our epilepsy surgery when we are handling focal lesions, and we can even help us to understand the depth of anesthesia. Apart from that, when the patient is being operated on a cerebral vascular problems or tumor problems, if we are compromising the blood flow, the EEG will help us to detect, because of the change in pattern of the EEG, that will tell us that there is something which is happening, which we have to alter and protect the blood flow. At the same time, during epilepsy surgery, mapping of the epileptic focus helps us to decide where exactly the focus is originating. Many a time, even in temporal lobe epilepsy, or once we do a temporal lobe surgery, like a medial amygdalohypopectomy, medial temporal lobectomy, after that we record the EEG on top of the surface of the brain, and we see whether the EEG suppression is achieved or not. If the EEG suppression has not achieved, at some forces there is spikes are present, that indicates that portion of the brain need to be resected. So this has helped us a lot to aid the patient to completely get rid of the epileptic focus in epilepsy surgery. The epilepsy, another part of the EEG is the electrocorticography, where the EEG and stimulation both helps us to understand where the motor and the functional component of the brains are by stimulation, and what is called the electrocorticography, and help us to resect the tumor in the perimotor strip area, where we can preserve the function of the patient without compromising the function. We can maximally resect the lesion. Another important aspect is the motor evoked potential, where we stimulate the part of the cortex with the low electrical volts intraoperatively. The main important aspect of all this intraoperative neuromonitoring is patient will not be paralyzed much, but by total intravenous anesthesia and analgesia with the scalp block, the patient will not have pain, and so the patient can be monitored very well, because when we are giving motor evoked potential, patients will have mild jerks, which should not be perceived by the patient. At the same time, when we are stimulating the cortex, the pyramidal tract take the receive the impulses, and which we can be recording in the peripheral muscle groups, which will tell us the integrity of the peripheral the pyramidal pathway, and helps us to understand that the integrity is good, so that we can resect more. This is very, very useful when we are doing it for brainstem, when we are doing it for spinal cord tumors, as well when we are operating on the cortical tumors, where we can directly stimulate, or we can use the surface stimulation and get what kind of results which you are getting. Even in spinal compressive myelopathies, cervical disorder, dorsal disorders, MEP, motor evoked potential, tells us the integrity of the pyramidal tract, which will help us and gives more confidence for us to work and decompress the cord as much as possible. The same motor evoked potential can be used for monitoring the lower cranial nerves, facial nerve, and the trigeminal motor component as well. By giving the motor evoked potential, we can elicit all the cranial nerves impulses through the recording device, whereby we know that the entire pathway is intact. Another major important factor is the monitoring the sensory part of the system. That is sensory, somatosensory evoked potential, where the stimulus is given from the peripheral nerve, the sensory part of the peripheral nerve, and the recording is done from the cortex, whereby we can know the ascending pathway is working well. Because when there is tumor or a pathology in the posterior aspect of the spinal cord, where the sensory component will be affected more, and when there is in the sensory areas, this SSEP will help us to define the pathway from periphery to the center, which is received by the cortex through the thalamus, that the entire sensory pathway is intact. So Any change in this according to the crossing, we can understand whether the somatosensory evoked potential is normal or abnormal. If there is a drop in somatosensory evoked potential, we can understand that there is something which we are doing is affecting the pathway, so that we can plan our surgery accordingly. There is another motor evoked system, what we call as D-wave recording, where instead of stimulating the cortex, we stimulate directly on the spinal cord, the anterior horn cells, through the placement of catheter in the epidural space or the subdural space on the spinal cord, and give stimulation. And at the same time record under the segment, 1 or 2 segment below the operating area with another lead, which will help us to understand what is happening between these two leads in the spinal cord, which is more focused than the motor evoked potential, and gives us a more informative information regarding the surgical modality. So any drop in D wave with some MEP lost is considered important, in the sense there is something which we are doing is affecting the spinal cord. So this will help us to define more better on the spinal, that to mainly intramedullary tumors below the CV junction, and help us to resect more, saving the vital structures without damaging further. It's all mostly the complete team where involved by a neurosurgeon, EEG, IONM technician, neurophysiologist, neuroanesthetist, and the entire OT nursing team. With all the coordination from everybody, it makes much easier for us to understand this intraoperative neuromonitoring and have a safe neurosurgical outcome for the patients. The most another important aspect is the awake craniotomy, where we do corticography, EEG monitoring, functional monitoring, subcortical fiber tracts monitoring when the tumor is involved in the functional regions of the brain, and when we are doing on a trigeminal neuralgia or any cranial neuralgia where patient has severe neuralgic pain in the cranial nerve distribution, which by awake surgery we can clearly supervise whether the patient has got complete relief of the pain or not. As well in hemifacial spasms, where we can see the significant drop in hemifacial spasms of the patient after the decompression. So we map the entire cortex, give a stimulation. Initially the patient will be sedated. Once we open the bone skull craniotomy, once we open the dura, we map the cortex by stimulating and seeing whether the patient has a speech arrest, motor arrest, and which part of the brain is controlling the each vital function, following which we can identify the tumor and resect the tumor safely. We can do even subcortical stimulation and see if the patient is developing any weakness as we resect more and more tumor, so that we can safely resect the tumor to the maximum with no fresh neurological deficits. And if there is some portion which is overlapped by the tumor and the eloquent area, we can leave that small portion, which we can treat by further radiation or chemotherapeutic agents. So in IONM, the MEP is mainly used for spinal cord surgery, mainly tumor, degenerative, congenital like tethered cord or meligomyloceles, and spinal column corrective surgeries like scoliosis correction surgeries, including brainstem and CP angle surgeries. The main use of bipolar and monopolar stimulations are, we use it for meningomyelocele to release the tethered cord, ruling out all the other cranial nerves, peripheral nerve tumors, peripheral nerve surgeries, brachial plexus surgeries to identify the vitality of each roots, jugular foramen, CP angle tumors, facial nerve re-neurotization, CV junction tumors, etc. D-wave mainly in case of spinal cord tumors. Mostly it is all a combination of multimodal monitoring, which is essential. One single modality alone may not help us to understand whether our monitoring is full, complete and whether our motor and sensory system all are safe. That is why the combination of EMG, MEAP, SSEP, bipolar stimulation, like that, each type of surgeries need different multimodal monitoring for a safe and successful surgical resection. So we have been using it for many intradural, extramedullary, intramedullary tumors, CP angle tumors, congenital pathologies, brachial plexus surgeries, gliomas, brainstem lesions, and so many. Near about every aspect of neurosurgery can be safely done with intraoperative neuromonitoring for a safe outcome of the patients. The main precautions to be taken are the electrical gadgets which we use, so many have disturbances which we have to neutralize with proper earthing, as well the proper maintenance of the equipments and anesthesia. Mainly we should avoid hypothermia. We have to maintain the volatile agents appropriately. Sufficiently we have to use the doses of intravenous anesthetic agents. Any change of this can give a falsified information of the neuromonitoring. Any decrease in MEP can be because of hypothermia, anesthetic agents. We can sometimes get focal convulsions during surgery, which can be controlled with saline washers. All EMG, EEG, D-wave, everything can alter based on hypothermia and the drugs. So when you interpret, more than 50% reduction is what considered as important change. And when we interpret, we have to make sure that the patient doesn't have hypotension, patient is not under hypothermia, and he is in optimal intravenous doses of sedation and no muscle paralyzing agents. So this is few examples. Here is a case with a large brainstem cavernoma presenting through the fourth ventricle in projecting out from the brainstem. So this is what we call telovelar approach, where we raise the tonsils of the cerebellum, go into the foramen of Magendie. What we are opening out is the midline of the brainstem. We use bipolar stimulation to map the hypoglossal nucleus, trigeminal nucleus, facial nucleus, and then through the bile breach, the cavernoma has been excised safely. Using all this multimodal monitoring, including somatosensory, motor evoked potential, and cranial nerve stimulation, helps us to safely do these surgeries even in the brainstem without giving any fresh deficit. This is the post-op. And this is another patient who had another cavernoma in the brainstem, which was projecting through the middle cerebellar peduncle. So this patient, again, we had to operate this patient through CT angle approach. Open up the cisterns, identify the fifth cranial nerve. After dissecting and identifying the fifth cranial nerve, the middle cerebellar peduncle was identified, traced. The bile breach was identified. We used the bipolar stimulation to map the fifth, seventh, and the origin of trigeminal nucleus. Once the bile breach was identified, the lesion was explored further through the bile breach, and the cavernoma was defined. It was circumferentially dissected and removed in toto. So when we are all, the days are gone where we had to be afraid of surgeries in the brain. That too, if it is in the brainstem, it used to be very sensitive issues, in the sense patients will are very afraid when we are operating on the brainstem. But neuromonitoring helps us to do the same with a safe surgical outcomes. This is another patient who had posterior peduncular region cavernoma, again, which was exposed by supracerebellar approach. defined and excised. This is a patient who underwent surgery for trigeminal neuralgia in awake modality. You can see the fifth cranial nerve. On further dissection, the vascular loop could be identified, and the vascular loop was dissected off from the trigeminal nerve. After dissecting and placing the Teflon between the trigeminal and the vascular loop, we check with the patient whether he had complete pain relief. Most of the time, 98% of the time, we can see patient having complete pain relief. In 1 or 2 cases, we patient did not have complete pain relief, and when we searched for, we had another loop which was pressing the trigeminal. On further dissection of that loop, patient had complete relief of pain. So this is the advantage of having a intraoperative neuromonitoring, where we can clearly elicit the benefit of the intraoperative neuromonitoring by complete relief of the pain at the end of the procedure. This is a patient who had a vestibular schwannoma. So main disturbance in vestibular schwannoma surgery is facial nerve weakness. So to have patient with no facial nerve weakness, and if the patient had no auditory disturbance, then intraoperative neuromonitoring is a very useful tool. You can see we are retracting the cerebellum, dynamic retraction, and defining the capsule of the vestibular schwannoma. We map the facial nerve location before we incise the tumor to see that we are not handling the facial nerve. And as we decompress, debulk the tumor, periodically we use bipolar stimulation and check the course of the facial nerve and protect the facial nerve during our dissection, by which, like bipolar stimulation, as well cortical motor evoked potential, which shows the facial nerve stimulation also during the motor evoked potential, what is called facial MEP, and bipolar stimulation, whereby we can check the position of the facial nerve and preserve the course of the facial nerve. And this patient luckily had both facial and hearing preservation and doing well so far without any fresh neurological deficits. And this is a patient who had an insular glioma, where the insular lobe of the brain had gliomatous extension both into temporal and into the frontal lobe. We mapped with the corticography the speech area, motor area. Then we did a temporal lobectomy, followed by, which is part of the lesion, and the frontal and insular lobe resection. At the end of the procedure, patient had complete resection of the tumor with no neurological deficits. This is a patient with a spinal cord tumor, which we do with endoscopic tubular approach. This is the lamina. This is the dura after releasing the lamina by laminectomy. That's a quadrilaminectomy, and the dura is inside. We use intraoperative neuromonitoring, both MEP, SSEP, and bipolar stimulation. Dural hitches applied. This is an intradural extramedullary tumor, which was attached with one sensory root. We could trace the sensory root with intraoperative monitoring, and the tumor was resected in toto, safeguarding the roots. So with this, we know whatever we are compromising is not a vital structure of the brain or the nervous system, and excise it completely without new fresh neurological deficits. This is a post-operative MRI showing complete resection with no neurological deficits for the patient. To conclude, it is always, we all want to have a functional preservation with no fresh neurological deficits, and intraoperative neuromonitoring helps us to achieve this at a successful frame with live monitoring of the neural structures during the surgery. Thank you. Thanks for the opportunity.
So it was a thank you, Dr. Lakshminarayanan sir. In spite of your busy practice and busy schedule, you were able to come and attend this program. Thank you so much for your presence, and you may be of a great help to all the neurosurgeons, I think. Even Dr. Vikram sir was also thinking about more about the collaboration with you. And I thank Dr. Vikram for arranging a nice talk by Dr. Lakshminarayanan sir. And also you have given a nice talk. Thank you one and all for the nice session. Thank you.
Thank you. Thank you very much.
Thank you, sir. Thank you once again for having me. It was my pleasure interacting with all of you. Thank you.